Episode 25, Left Shoulder Pain in a Wrestler. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide practice questions at the end. Here's the case. A 24-year-old right-handed professional wrestler with no significant past medical history who suddenly developed severe left shoulder pain during sleep. This occurred 2 weeks after receiving his second dose of an inactivated COVID-19 vaccine, which was manufactured in China. I would note this vaccine is distinct and different from the mRNA COVID vaccines distributed where I'm from in the United States. His shoulder pain was intense and accompanied by subsequent weakness, persisting for about a week before gradually improving. 2 months later, he noticed infraspinatus muscular atrophy. By the time he presented to the authors, about 3 months after symptom onset, his pain had largely resolved. The patient described increasing weakness in the left shoulder, especially during competition. His examination demonstrated full active and passive range of motion, decreased strength in abduction, and more significantly in external rotation. There were no sensory changes described by the authors. Okay, my differential. Rotator cuff pathology, including tearing, cervical radiculopathy, peripheral neuropathy, and thoracic outlet syndrome. I want to recognize the authors. This is from a case report by Ganjeh et al. In BMC Neurology, 2024. I'm Scott Hull, a primary care sports medicine physician. I am studying for my sports medicine certification exam in 2026, and I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, diagnostic workup. His shoulder MRI was normal, with no findings of tendinopathy, ganglion cyst, or rotator cuff tear. The initial EMG showed a left suprascapular nerve lesion with fair reinnervation in the supraspinatus, but no reinnervation in the infraspinatus. This raised an important clinical question that the authors highlighted. If the suprascapular nerve were compressed at the scapular notch, why would the infraspinatus be more affected than the supraspinatus? This anatomy did not fit a simple entrapment picture. A follow-up, more detailed EMG confirmed the diagnosis. Findings consistent with Parsonage-Turner syndrome affecting the upper trunk of the brachial plexus, predominantly the suprascapular nerve, with the infraspinatus muscle more affected. The patient was referred to physical therapy with goals of maintaining range of motion, preventing further atrophy, and gradually rebuilding strength as nerve regeneration occurred. His exercise program was systematic. He began active exercises without weight for the first 4 weeks. Then resistance bands were introduced with progressive resistance up to 3 months. Then weight training started at 50% of his 1 repetition maximum, adding 5% weekly or bi-weekly based on tolerance, continuing through month 5. At 6 months post-onset, he began sport-specific wrestling training under supervision of both the physical therapist and his wrestling coach. 5 months after symptom onset, his muscular strength began returning and the atrophied muscles started recovering. By 11 months post-onset, the athlete was competing at the Asian Championships. Currently, he reports no pain, no weakness, and full return to both daily activities and professional wrestling. The authors include a picture of before and after in their paper, and the differences are very striking. You can clearly see infraspinatus atrophy at 3 months and the remarkable recovery at 1 year. Key takeaways. Parsonage-Turner syndrome, also called brachial plexus neuritis, is an idiopathic inflammatory neuropathy characterized by sudden onset of severe shoulder and upper arm pain, followed by patchy muscular weakness and atrophy in the affected limb. The syndrome follows a characteristic pattern. Intense, often excruciating shoulder girdle pain developing abruptly and typically without preceding trauma. This pain phase lasts hours to days before spontaneously improving. As pain subsides, patients develop weakness and muscle atrophy, usually appearing within days to weeks of pain onset. The suprascapular and axillary nerves are most commonly affected, though any nerve in the brachial plexus distribution can be involved. Unique to this case, the association with COVID-19 vaccination is now well documented across multiple vaccine platforms. The author's literature review catalogs cases following Pfizer, Moderna, AstraZeneca, and Sinopharm vaccines. This does not mean that we should be avoiding the vaccine. This condition remains a very rare possibility, but we should be aware of this potential association. The diagnosis relies on clinical presentation supported by electrodiagnostic testing and potentially advanced imaging. Treatment is primarily supportive. High-dose corticosteroids may assist with initial pain control, though evidence for improving weakness or long-term outcomes is very limited. Contrary to traditional teaching that most patients fully recover, recent data shows that some patients may never achieve complete recovery. Factors associated with incomplete spontaneous recovery include older age, bilateral involvement, and a greater number of muscles affected. Younger patients with unilateral symptoms and trauma-related onset have a better prognosis. Okay, questions. Number one, a 35-year-old female CrossFit athlete presents 6 weeks after sudden onset of left shoulder pain followed by weakness. An EMG performed 4 weeks after symptom onset shows fibrillation potentials and positive sharp waves in the left supraspinatus and deltoid muscles with reduced motor unit recruitment. MRI of the shoulder shows no rotator cuff pathology. MR neurography of the brachial plexus is obtained. Which of the following MRI findings would be considered pathognomonic of Parsonage-Turner syndrome? A. Diffuse T2 hyperintensity of the brachial plexus. B. Hour-like constrictions of the affected nerves. C. Fatty infiltration of the supraspinatus muscle. D. Enhancement of the C5, C6 nerve roots. E. Edema in the scalene muscle. The correct answer is B. Hourglass-like constrictions of affected nerves are considered pathognomonic findings in Parsonage-Turner syndrome and have been identified in over 90% of EMG-confirmed cases in tertiary referral center studies. These focal areas of decreased nerve caliber or diffusely beaded nerve appearance can be detected on MR neurography and high-resolution ultrasound. The identification of these structural nerve pathologies has transformed diagnostic accuracy and opened the door to surgical intervention in selected cases. Diffuse T2 hyperintensity and muscle denervation changes are supportive but not pathognomonic findings. Fatty infiltration represents chronic denervation changes seen in many different conditions. Nerve root enhancement would suggest radiculopathy or other inflammatory conditions, and scaling muscle edema is a nonspecific finding. Question 2. A 42-year-old male tennis player is diagnosed with Parsonage-Turner syndrome, affecting his dominant right upper extremity. He is anxious about his prognosis and return to sport. His EMG shows involvement of 6 muscles with active denervation. Based on current evidence, which of the following factors is most associated with incomplete spontaneous recovery? A. Male sex. B. Dominant arm involvement. C. Bilateral involvement. D. Vaccination as the precipitating trigger. E. Age younger than 30 years. The correct answer is C. Bilateral involvement is strongly associated with incomplete spontaneous recovery in Parsonage-Turner syndrome. In a study of 100 patients with 144 affected extremities, bilateral cases had a 93% decreased chance of spontaneous recovery compared to unilateral cases. Additional factors associated with incomplete recovery include older age and greater number of muscles affected. Interestingly, traumatic antecedent events were associated with better spontaneous recovery compared to other triggers. Male sex and dominant arm involvement have not been shown to significantly affect prognosis. Younger age is actually associated with better outcomes, not worse. Okay, question 3. A 30-year-old professional baseball pitcher develops Parsonage-Turner syndrome, affecting his throwing arm. After initial management with corticosteroids for pain control and physical therapy, he shows minimal improvement in strength at 14 months of symptom onset. MR neurography demonstrates hourglass-like constrictions of the suprascapular nerve. Which of the following is the most appropriate next step in management? A. continued conservative management for an additional 12 months. B, referral for surgical neurolysis and decompression. C, IVIG. D, repeat high-dose corticosteroids. E, immediate tendon transfer surgery. The correct answer is B. For patients with identified hourglass-like constrictions who fail conservative management after 12 to 18 months, surgical neurolysis and decompression have shown promising results with superior outcomes compared to continued conservative management. Next question. A 25-year-old female soccer player presents with acute onset of severe left shoulder pain that began 5 days ago. She reports the pain is improving but notices new weakness with shoulder abduction. She had an upper respiratory infection 2 weeks previously. Physical examination reveals weakness of shoulder abduction and external rotation. You suspect Parsonage-Turner syndrome. Regarding the timing of diagnostic studies, which of the following statements is correct? A, EMG should be performed immediately to confirm the diagnosis. B, EMG abnormalities may not appear until 3 weeks after symptom onset. C, MRI of the shoulder will definitively rule out Parsonage-Turner syndrome if normal. D, nerve conduction studies are typically abnormal within 24 hours of symptom onset. Correct answer is B. Electrophysiologic studies are considered the most important diagnostic tool for evaluating peripheral nerve injuries in Parsonage-Turner syndrome, but they typically require up to 3 weeks after initial nerve insult to display abnormalities such as fibrillation potentials and positive sharp waves. This delay reflects the time needed for Wallerian degeneration to occur and become electrodiagnostically detectable. Thank you. We'll see you next time.